So I'm hoping today to just start to open up the topic of case reporting and to do that with you all. I'm thinking of this as a conversation that we might be having together over a cup of coffee and opening. And before we met, I was talking with Anne on the internet, and within 15 minutes, we're talking about a case. So I'd just like to put that there as a little marker for everyone. I'm going to do my best to stay on topic and be clear. And please remember, anything that I say today is really not fixed. It's not a law, and it's able to be expanded and discussed. It is a continuation, really, of a long discussion that we've been having in homeopathy for about 200 years or so. For a moment, I thought I could give you a webinar on what we could do to write up your clinic cases and get them published. And if I was going to do that, I'll be telling you a lot of things and you'd be thinking that's great. And we'd all be in agreement, yeah, that's what we need to do to write up a case. And at the end of it, neither you or me is going to have written up a case. And I think I'd be prepared to make a small wager that at the end of a month, none of us is going to have written up a case if I do that. And again, at 6 months' time, probably most of us won't have written up a case. And for full disclosure, I just want you to know I've never written up a case for publication. So this is the landscape that I'm describing and that we're walking into together. But so why am I making these kind of, quite outlandish claims? And what on earth is going on for me to be saying these sorts of things? So we will be going through a few guidelines and blueprints and ideas about what matters in a case. But first, I'd like to take us a step back and consider some other matters that coexist with the act of case reporting. And I'm trying to make my computer go to the next. Why is it not going to the next? There it is. Found out how to do it. So over the next little while, I'm going to focus on three sorts of things. One I'm calling flow, and that is really, where did case reporting come from? Why is it important? And what can we do to increase our writing of cases? And then I'm going to go through some guidelines, but not in a great deal of detail. And throughout this little period of time, if you've got questions or comments on anything that I'm raising or talking about, can you use the chat box and record them in the chat box? If Anne will keep an eye on it, and I didn't check with her earlier, but I know she will. So if there's something that's really, pertinent to write at that time to discuss a little bit more, she'll interrupt me and we will discuss it right then and there. But if it's something else that we can wait till the end of the presentation, we can do it there as well. The point is that I don't have all the answers at all, and we're still really in an expanding, trying to understand what is necessary for us to be able to do a case report. So all of your feedback and thoughts are relevant. So where did case reporting come from? This is a beautiful quote from Constantine Herring in 1848. And we have to thank Linley Jordan for finding this little gem, which I'm now going to share with you all. Basically, and I'll modify it slightly. He says, if every homeopathic physician would record her experience, if she would carefully observe groups of symptoms or single symptoms, which the remedy she had selected cured, either alone or in conjunction with other remedies, if she would record new symptoms which a remedy frequently produces in a patient, and if these observations were sent to the Bureau for Materia Medica, whose business is to collect and compare the experience of one with that of another, we should soon gain the greatest certainty of our practice. In 1848, this is what he's basically saying, this call. And we know from the research that many others have been doing that even Hahnemann was recording his cases, communicating with other practitioners at the time. So from the very beginning of our discipline, if you like, case reporting and sharing has been important. And so I would say to you, really, and you know this, it's in a clinic where we find out firsthand how the remedy works. Up until that point, it's everybody else's knowledge, and it's not the knowledge for that patient that's come through the door right then, that moment with us. And we've gone through the process to determine what remedy to choose, given what we can see and discern from and with the patient. But we're still like a blind woman touching the trunk of an elephant. We touch the trunk, we recognize that it's an elephant, and we figure out the path to take because of our training, understanding, and knowledge shows us which direction to follow. But it's only describing, in essence, part of the picture. The totality is not ever really known necessarily. And this patient that we're seeing is new. Their life experience is new. Increasingly, patients turn up with a host of existing drug exposures, health interventions, lifestyle impacts that didn't exist in Herring's time, that didn't exist 40 years ago, and we could go one further, didn't exist 5 years ago since COVID. So this patient's experience is the new experience of how this remedy is either supporting us or not the healing process of the person. So the patient is bringing a new picture of the totality of the remedy to us when we prescribe it to them. And so this is what Herring is asking of us way back in 1848. He's saying, record, share these experiences, let us understand. If we don't record and share, are we saying that all knowledge about the remedy is already known? Is our discipline a fixed or a dynamic one? So now I want to go a little bit tangential and put some ideas to you about if I was to write a case, what would I focus my case on? So here are a few things that came up for me in my mind that could be the focus of a case report. It could be the patient. It could be the remedy. It could be the diagnosis. It could be the approach taken. It could be the beautiful, strange, rare, and peculiar symptoms. It could be materia medica. It could be philosophy, symptoms, you name it. A case report doesn't need to be just one single focus. It can have several. It's pretty clear that in many case reports that have been published over the decades and centuries, that different things interest different homeopaths. Sometimes in the British Homeopathic Journal, you can read about a case that's a couple of inches long in a column, and it might read something like this: male 46, acrid urination and lost bladder control, recent death of wife. After usual remedies have failed, this one in 6x 3 times a day for 2 days has cured the issue. And that's the case. Not very detailed, but it's a communication. And it's not up to the standard of what we need to have cases today focusing on. We also have cases, of course, that you would have read in Similia that have got longer narratives associated with them, especially in the sensation method. This is more likely where the actual words of the patient are reported verbatim and remedies are given, and responses of the experience of the patient are then further reported. So more recently too, we have tighter case reports. Often it comes with levels of health approach, but it can be any type of methodology using a tighter type of case report. And this systematized reporting approach might also use a tool called Monarch. And Monarch is a tool which allows us to say that the treatment in the case actually was the cause of the cure or cause of the outcome. So it moves the case from being observational into causative, providing the requirements are met in the case reporting. And that's very exciting that we could have cases that actually show the effect of the treatment rather than just observing it. So it's really just a matter of perspective. There's no right or wrong thing that we focus on in a case. It could be a chronic incurable condition, rock solid prescription of a polyfrost remedy, exploration of how a case is managed, the flow of changing symptoms and remedies, an acute case, and there could be many other reasons to write a case that I haven't been able to record right now. So the question to consider, I think, is what is it that makes you feel like that this is a great case that could be shared with your colleagues? And I think this is the beginning spot, is to find that little spark and inspiration of, I want to tell you about something that happened in my clinic with this case. So psychology explains a lot about what we are doing and why we write or we don't write up a case report. And I'm going to say, firstly, that we as homeopaths are very highly motivated people. In psychological terms, we're going to call this intrinsic motivation. We don't do something because it's being forced upon us. The carrot and stick approach usually doesn't work very well because we don't need a carrot and we don't fear the stick. Money, which is often a very good external motivator, we could maybe potentially say doesn't drive us solely either. Yes, we need money to live, but we don't ditch homeopathy because we don't earn enough money from it. We always have a plan B. Now, we haven't measured the level of motivation or the type of motivation in the homeopathic profession, but the very fact that our profession is under such strong negative social discourse and that we continue to practice despite this is indicating that our motivation is intrinsic. This means that we're not getting validation from the broader world or society around us. Instead, we're being motivated from within, from doing what we feel is right and correct and feeling good when our patients do well in treatment. We can also have a tendency, because of this, to think and to come from the belief that 100% is the minimum requirement. And this, I think, could be a block for us writing up our cases. It's potentially a limitation and a bar that we could be setting ourselves. And for some of us, it will also stem back into our previous studies. For example, when we learned about the simillimum, there's been this kind of like sense of we must try to prescribe the simillimum under all circumstances, or we will have failed in some fashion and not achieved the 100% correct space that we need to be in a case. So unless all of the case is resolved, we might have a feeling that we've failed the case in some way or failed the patient. It takes quite a lot of practice to unlearn these ideas and to allow ourselves to move into a best rather than 100% space. And as I mentioned at the beginning, Anne and me were talking for about 15 minutes and already talking about a case. And I'm sure many of you have been at a conference and met up with new people, and within minutes, people are talking about this great case that they've had in their clinic. So there's a kind of like, we have the interest and the engagement to share what's going on. We want to know what the person that's sharing their case did and what remedy they gave. And as they're talking, we may come up with an idea in our own mind, oh, I wish they'd given this remedy. And then we find out they did and it didn't work. And they tell us what happened. And, there's a to and fro in discussion going on. And our interest is piqued. It's exciting and engaging for us. So we can be curious and engaged and not necessarily judging the other to be deficient or wrong, like we might judge ourselves when we think about our own cases and why we can't write them up. We can be excited and thoughtful about what the other person has done. How did they manage the case? And we think of many questions to ask. So this is leading me to think about things in terms of how could we possibly do case reporting together so that we could potentially overcome some of this blockage that we might impose on ourselves. Oh, I can't make it go forward though. Yes, I can. There's another element with regards to case reporting, and that can be that we can feel uncomfortable if we start to look into a case in our clinic that we think might be good enough or something that we might want to share. And the feeling of uncomfortable, just as a very general sense, we don't like feeling uncomfortable, so we avoid it. And The problem is that in that avoidance, we may not write up a case that could be very beneficial for other people to learn about and to read. So case reporting is a process where we start to examine what we did with the client, and that unrealistic bar of 100% can make us feel very uncomfortable when we kind of push into it without kind of being aware that that's maybe what we're doing. There's also one extra thing that could come into play, and that is that the world around us is saying homeopathy is flawed, unethical, immoral, and wrong. So we're living in a world where this is kind of the discourse around us. And when we start to look into the cases that we have, and we start to maybe question what we did and come into that place of realizing, oh, I didn't do a perfect job, that we might slip into looking at the outside world's assessment of homeopathy, and it's saying all of these bad things about us. And so we're getting this kind of like negative reinforcement, and that could be the wrong term, but a negative image of what we're doing from the outside world. So it can shake our, I don't want to use the word faith necessarily, but it can certainly shake our confidence of doing something very fundamental and critical for our profession, which is to record our cases and share them. And I'll feel uncomfortable and I won't want to stay in that space necessarily. So I might become too busy, or I say that I don't have enough follow-up, or I don't have enough data, and I won't do it. Whereas if I go to the conference and I have a coffee, and in the break of the conference, there I am talking about the case. So there's something in there to look at. And we can't look at it if we don't look at it. Like if we turn away from being uncomfortable, we won't be able to push through into the place where good cases could be brought into the sharing space for each other. So I hope I'm painting a bit of a canvas for you all to sort of see what the issues are in the background. There are a few other ones as well, but these ones are kind of like the big ones. And the only people that can overcome them are us, the practitioners. So it's something to be thinking about. Oh. So I'm going to move on to why is it important. It's very important that we write up our cases. Very important. Cases share knowledge of the remedies and their action. So if we're going to allow the knowledge of our discipline to grow, we need to be recording and sharing that information with each other. I'm going to put on my other hat now as the research coordinator. Good quality cases are so important for the research that we can do as homeopaths, and they're fundamental to us. So they highlight the benefits of homeopathic approach for patients with conditions. They can raise the profile of homeopathy internationally, and also they can contribute to, good quality cases can contribute to international projects like Glyphicol, in particular around COVID cases, and they've expanded their work now into female disorders. So we were having trouble potentially politically to prove that homeopathy works as a discipline. The cases have reported such wide variability in their content, and often claims of cure without direct evidence that it was due to the homeopathic treatment given by the practitioner. So the international community has, over the years, put together some guidelines on what a good quality case would have in it. And this has been published since 2016. Just going to go there. And it came out of medicine, actually. So in medicine, there's a history of case reporting, just like in homeopathy. And in medicine, it's a strange or rare medical situation that usually has a unique treatment or approach used. So the first time something is done is often in a case report for medicine. It reports whatever the condition is in the treatment and highlights why the practitioner thinks it's significant. And this has got everything to do with homeopathy, because you can see right there that that's what we do every day with the client that comes into our practice. The only difference is that in medicine, they have a diagnosis, and for us, it's the patient. So these medical case reporting guidelines, because medicine was in a bit of a melange of different cases, no structure, no kind of a formalized way of reporting a case. So the case just becomes a narrative and becomes very difficult for people to collate cases together and say anything about the cases that are being reported. So the medical community made this care case report format, and the homeopathic medical community extended those reporting guidelines to accommodate homeopathy. And they were first published in 2016 and then updated in 2022. Now, don't try to write all this down. Anne's got a list of everybody. If you want a copy of these guidelines, we can send you an email and send you these slides. So it's a lot of detail in there. But I wanted to just draw your attention to the fact that there's 13 different categories, and I'll show you on the next slide. And this is what they are. So if we're going to try to make a case report that has some sort of structure or a guideline or blueprint, it's going to have a title, it's going to have keywords, abstract, which is a summary of the entire case, an introduction, patient information, clinical findings, a timeline, diagnostic assessment, which would be something around testing, therapeutic intervention, which is what did you do homeopathically, follow-up and outcomes, a discussion, a patient perspective, and informed consent. And a lot of these things we already do in our case reporting. There are some things that we can refine a little bit. The title may not necessarily reflect what the case is about. So a title that reflects what the case is about, keywords that reflect what the case is about, and an abstract are essential, because these days databases and searching tools are looking, and they look at the title, the keywords, and the abstract. So how we record what we're doing or what the case is about in those these three areas is really important for people being able to find our case reports. But the thing that I want to do now is just say something about the title, I think. Yeah. So the title of the case, and I'll put this slide back up, might be something where we want to explain what the case is going to be focusing on. So it's very easy when the case is around a diagnosis to put the diagnosis. So, for example, if it's that male, 46 years of age, and he's got acrid urination and bladder failure, then that could be, if you like, some sort of a diagnosis, and that could be part of the title. So it's very clear the case is going to be about this. But if there is no diagnosis, and if the case is about really a remedy, or it's a case that is going to be exploring the materia medica in some way, the title needs to have that included in it. Now, sorry guys, there we go. I'll just go back to this as the list of all of the 13 areas. I want to just draw your attention to two things. One is that a lot of our traditional cases written up in the recent years we'll follow a process of talking about the first consultation and then describing the rubrics and remedies given, and then the follow-up consultation. So there'll be this kind of like flow of a consultation, action, follow-up consultation, action, follow-up consultation, action. In using some guidelines, these guidelines or blueprint, they've kind of highlighted a timeline. And so we do have a timeline embedded in the way that we write in traditionally our cases. But this timeline really is about the patient and the patient's timeline. So what is happening for the patient could include what's happening with the homeopathic treatment, but also some other things. And particularly these days, if patients are having other treatment, conventional medical treatment ongoing, if it's a chronic condition, that's quite possible. Or they may have had earlier, before starting homeopathy, some treatments and then homeopathic treatment. So the timeline is a snapshot of seeing the medical or the homeopathic medical treatment process, but also the significant life events that occur during the course of treating the client that might have an impact on the way the case is unfolding. It's very handy to have that kind of a snapshot picture exposed and able to be seen easily. And the other area that I wanted to draw your attention to here is the patient perspective. It's like right down at the bottom of the 13 things. And in the care reporting requirements, it says it's optional. And I'd just like to share an experience that Ilma, who's here today too, has been writing up a case with one of her patients. And I've been talking with her about it. And we asked the patient if they would be prepared to write something about their experience with the treatment over 20 months. And we offered the patient the opportunity to write that reflection of their experience. And we said that we were going to publish it with no changes. So whatever they said, that was going to be part of the case that we were writing up. And we didn't quite realize until the patient made the reflection what a powerful act asking the patient to reflect on their process had been. We could not have imagined what they would have said. And I can't recall reading another case report where the patient's perspective of their treatment process has been given. And so I really want to just kind of highlight that as a thing to consider, asking your patients, even if you're not going to write up a case report, but asking your patients to write some feedback to you about what it is that they have experienced over a period of time. So in Ilma's case, it was 20 months. And we had no idea what this gentleman was going to say. And the eloquence with which he explained how his life had changed because of the treatment, I think it became like an extra layer of something that we didn't realize, even in the dialogues and the case report that was being reported. So it's something that's I would suggest is a very interesting thing to do. But then, of course, the person could reflect that they don't feel like very much has happened and that they feel like homeopathy is a waste of time, or that they haven't got what they thought they were going to get and they haven't been able to figure out how to stop doing the homeopathy. Anything can come up in that space. I notice how I just pick negative things. I think more often than not, we'll probably find positive things because people are suffering and they're looking for a change when they're undergoing homeopathic treatment, and often this is what happens for them. So anyway, if you would like to read that particular patient perspective, you can, because it will be in December's 2024 edition of Similia. This is my shameless plug for opening the journal at the end of the year. So There is a couple of other things that are worth thinking about. And the key one is to think about when we're writing a case, it exists in something. The person who's come to see us lives in society and they have a condition or they have a set of symptoms. They're not extracted out of the environment that they live in. And when we're writing up the case, I think it's very useful to think about how do we put the case that we're writing up into the context. So if it's a materia medica focused case, we could place it within the materia medica of the particular remedy and then extract out what new things we've learned. Maybe there's a rare symptom or a new symptom that has been unknown up until this point about that remedy that is seen in this case. So that could be something that occurs in the introduction and the discussion. Or if the case is for symptoms about a disease, maybe a chronic incurable disease, exploring the conventional treatment of that disease might be useful for people to understand. It might also help you understand what the patient is bringing with them into the consultation. You add more to the case and the readership, you add more to the readership's understanding of the condition when you put it into the context of this particular diagnosis. This is usually what happens. And then you can also ask, has anybody in homeopathy published a case on this condition? And go and have a look. And so if there's other cases on this condition, you could bring those into your case report as well and just sort of see, what have I done here? I gave this remedy and had these symptoms. They gave that remedy and had those symptoms. That could be an interesting thing to reflect about. There could also be several different approaches to think about. So for that perspective, there could be medical approaches, psychological approaches, and even sociological approaches. Particularly these days with chronic incurable diseases, there's a lot of research about the lived experience of those conditions. So exploring some research into those areas of how people are living with a chronic incurable disease can sometimes add more understanding on the experience that your particular patient has got. And so all of these things can be included into the into the case report. So, and I just wanted to show you a timeline might look something like this. So significant pre-treatment symptoms, first visit and prescription, second visit, significant symptoms and events and outcomes from the first prescription. The timeline might move along and have 7 or 8 or 10 or 15 points on it. And you might highlight at this point a significant change happened in the case. So it becomes like a visual snapshot for people to look at and understand the case and then go into the detail of what you've written. So the main takeaway of all of this is that if you've got a spark of interest, a spark about a case that looks interesting, but don't feel like you could write up a case on your own, then you don't need to do it on your own. I think that the act of writing up a case is better done with others. And you don't need to have a special voice. There's no special scientific case reporting tone that one has to write. I think bringing your own voice as the practitioner into the case report is critical because the patient came to see you. Patient didn't come to see me or Anne or Ilma, came to see you. And so whatever happened between you and that patient is a dynamic, which is part of the healing process. And finding the ways to bring that into the case report so that your colleagues can read that and begin to understand, this is what you do. This is how you think about it. That's interesting. That could be a learning point for me as a reader of your case. So I make the assertion that you as the practitioner do matter in the case that you're reporting. And I think that because if you don't matter, if none of us matter, then we could just use AI eventually to get a remedy. And I don't think any of us think that that's true. So there is something about us, I think, at this stage to reflect and bring into the case report, not try to cut it out and just make it about the patient. It's more. That's my belief, anyway. It may not be for every case, but I think it's a useful thing to think about. So I'm thinking that later this year and next year, we're going to set up some case report workshops where we can come together in small groups and work with each other. And the reason for that is that while I personally might feel like my case is not worthy of publication, I already know that when I start talking about it, other people are going to say, oh, no, you should write that up, because they already do. And you should write that up. So together we can overcome some uncomfortable feelings and share our cases with each other in the world. So that's what I've got to say today about case reporting.